Welcome to the Health Systems CIO Show. I'm your host, founder, and editor, Anthony Guerra. On today's episode, I'll be speaking with Colleen Mallozzi, SVP and Chief Nursing Informatics Officer with Jefferson Health. Colleen, thanks for joining me today.
Thanks, Anthony. Excited to be here with you.
All right, great. Do you want to start off by telling us a little bit about your organization and your role?
Absolutely. I'm the Chief Nursing Informatics Officer for Jefferson Health, which is a health system based in the greater Philadelphia area, spanning from New Jersey to the Pocono Mountains, and a little bit beyond. So I oversee a team of 34 informaticists, which support the 33 hospitals that we have, as well as the over 700 ambulatory sites of care.
All right, very good. So we're going to talk a lot about nursing today, which is great. Doesn't get enough attention. I have to tell you, I'm married to a nurse practitioner, so
Love that.
I have some inside baseball information on the job a little bit. So you've been writing recently about some of the needs of nursing, whether they're being met or not, that they need to be sort of get more specific and sort of customized attention as opposed to everything just flowing downhill from work that's being done to take care of the physicians. Just tell me sort of a little bit about your thinking and maybe some of the stuff you're working on, and we'll go from there.
Sure. I think one of the recent things I've been talking about is ambient technology and how it varies quite a bit in the nursing space than it does from the physician space. So physicians write notes in prose and go through their assessment plan, and nurses really function pretty heavily in structured flow sheets. So as we're looking at this technology and the potential for what it can bring, we're working closely with the vendors who are purposefully designing it for nurses so that it's vocalized care that goes to structured flow sheets. And since that's how nurses document, that's the way that it works out nicely. But it's a very different approach to implementation. We have to go out and spend a lot of time with our nurses in the field, on the units, seeing what this is. A lot of internal monologue is used when a nurse is doing an assessment. They're quietly maybe jotting notes on a piece of paper, but they're really processing in their head. And in order to move to ambient care, it's a little bit of a unnatural progression. So we're now
Hmm.
saying, vocalize your care, be conversational about it. And to be honest, that comes with time, and it
Yeah.
comes with wisdom of time at the bedside when you feel really confident in your assessment skills. So this is
Huh.
shaking things up again, up a bit, but I think it's in a very positive way, what we're seeing.
It's a really interesting point. People are all different, but I guess you could have predominant ways that physicians like to practice. So you can speak collectively about nursing in a sense, but then if you break it down further, their individual nurses have different preferences. For example, I know that if I'm writing something, I do better if I'm typing it, writing it, as
Mhm.
opposed to some people who are really good at dictating the piece they want to write and just talking it out, but I don't really work that way. So,
Amazing.
but it's interesting how you mentioned, how people like to work. And if you're just vocalizing what you're going to do and other people are around, and, you could be a little uncomfortable, a little self-conscious with that.
Absolutely.
So it's just interesting. Any more of your thoughts around that?
So you're so spot on. When I went to college, I would have to write out my notes and then I would type them out and then I would study them. That was my process. And I'm not as much on vocalizing it. I think what we're finding are all these really positive benefits of vocalizing
Hmm.
care. It's that engagement with the patient. If you're vocalizing what you're doing, they're being educated to your process, to your thinking, to how you're working through their disease process or the coordination of their care or some of the psychosocial aspects that come with being a patient in an acute care hospital. So I agree. There's this kind of hump that we have to get over,
Hmm.
which is this feels maybe unnatural because I was doing it in my head and now I'm doing it out loud, but it's not performance for AI. it's a movement to conversational care with patients, which
Hmm.
helps to embrace them in their care. And I think the more that we can talk about that and help our nurses work through the initial discomfort of this type of practice,
Hmm.
we're going to get there. But it takes time, it takes simulation, and it takes engagement with them to say, like, you're safe in this space. And while you may not feel super confident in verbalizing your assessment skills, we're not going to hold it against you. We're going to work with you as you gain this new skill of verbalized care.
Yeah, I believe I read that you might have been saying that there's a percentage who are hesitant. I think the word hesitant was about
Yeah.
30%, but it was interesting that and it's correlated to experience. So the younger nurses are more hesitant, perhaps, to be vocal. But, that goes against, it's a little counterintuitive when if we think about it, if we don't think about it that way, but we think about technology adoption, sometimes we think older workers are going to be more hesitant to adopting new technology, but this is younger workers and it's due to experience as opposed to technology. So maybe you're getting it on both ends of the spectrum, hesitancy. So you got to work through all that.
We are, and we like to call them seasoned
There you
workers.
go. That's the word. Yep.
But it makes total sense. Think about it. This is not about technology. It's not. It is about transformation of their practice. And someone who's been practicing nursing for 10 years has the confidence and wisdom of that time at the bedside where they're not questioning maybe what's coming out of their mouth as they're working through the assessment. And the newer to practice nurses are still getting their feet wet. What's their style? How do they like to approach a patient? Is it from the head to the toes? Is it from the psychosocial aspect first and then create that safety in the relationship and then work your way out? You really have to frame the overall approach a little bit differently, and that should be personal. Our practice should be personal, but
Hmm.
each group is going to work through it a little bit differently how we do
Hmm.
this. And we have 5 generations of nurses working right now. So there are quite a bit of differences in how they approach this.
And do you start with the why? So, as you
Yes.
mentioned, this is a better way to practice that we've decided from clinically speaking, there's much upside here. So you start, and I'm just talking out loud, and then you
Yeah.
start by explaining the why, and then you try and help them through the how. Because if they know the why, then it's, oh, this is why you want me to do this thing that I'm finding uncomfortable. I can see your upside, so I'm going to embrace this,
100%. And actually, they have to develop the why with us.
right?
We didn't come here and say, we're implementing this. So, whoever you're going to have to be a part of it. We said, we have this opportunity. We have this opportunity to transform the way that we care, the way that we engage with our patients, to reduce the burden of the 2.5 hours per shift that you're spending document. So this is what we have. Do you want to be a part of it? And then they raise their hands. And that's them co-developing the why behind why we would want to implement technology like this.
Hmm.
No one in life likes to have anything forced upon them, forced change just because a company walked in the door and said we had the shiny object. We truly believe that this is going to change interactions and
Hmm.
make them more human, not
Hmm.
less. And that's the piece that I really want to be a part of the conversation because artificial intelligence is scaring people. It's a turnoff. And we want this to be, it's actually creating an opportunity for more humanistic interaction and taking away the administrative burden of that EHR that we gave them decades ago.
Yeah, I mean that's 100% right on. So, but you're right, it's counterintuitive. Again, we're rolling out AI and they go, "Oh my God, no, I don't want more technology. I want to be with my patients." But no, that's
Mhm.
the whole point. The whole
Whole
point is
point.
we're going to offload a lot of this stuff from you. So things you would have had to sit there and do after the encounter are going to be done. You just have to check them and review them.
Exactly.
So you would imagine that's got to be music to their ears, right?
You would imagine, but it's clunky in the beginning. It's uncomfortable. It is takes longer in the
Yeah,
beginning. That's what we're
yeah,
finding. So you
yeah.
have to find people who are willing to innovate, and innovation in and of itself is going to be a little bit uncomfortable. And that's who we're getting out and sitting down with. And we're kind of interviewing them and they're interviewing us. Who wants to be first here? Who wants to be the
Yeah.
tip of the spear? It's going to be a little bumpy, but we have great partners across the
Well,
system.
I talk to a lot of people, have conversations, professionally and then in my personal life, people talk about AI. They want to know, what's going on with it, what does it mean and all that. And what I would tell you, you talk about making this opt-in, and that's very nice. But I would tell anybody who would like to who would like to continue to be a part of the workforce they're currently in, that you want to be on the right side of these decisions. So if you're given the opportunity to embrace some of these tools or go to a class or get a certification, do it, do it, do it, do it, do it. That's and again, I'm not we're not going to say that, you're gone tomorrow, but just this is the way the world is going. Be on the side of those that are engaging, embracing, willing to change. That's where you
Yeah,
want to be. Thoughts?
absolutely. It's it's hard because of what AI is. And, to be clear, AI, artificial intelligence has been around for a long time in healthcare. We have clinical decision support. We have deterioration indexes. We have medication alerts that help us make sure that they have been around for decades. It's this generative
Mm-hmm.
AI that's creating new outputs that's different. And then
Mm-hmm.
it's taking words and creating new output. So all
Mm-hmm.
right, that's our piece of this. I exactly what you said is where I'm at, but I'm sitting in the AI space. I try and often bring myself back to being a new nurse, and I wasn't focused on what is this computer system, what is this technology, what is it? It was how do I care? That's why I went into nursing. How do I care for patients and not hurt anyone? How do I do the right thing by them? So it's about meeting people where they are. I may be a nerd who loves technology, but not everyone is necessarily in this huge embrace of this AI revolution. They think it is not great for the environment. They think it is going to de-skill us. They think that there's bias introduced. So, all right, let's have those conversations. Let's figure out if that is a real problem. And if it is, how do we control for that risk and not introduce it into the clinical care? So it's just, there's so many thoughtful conversations going
Mm-hmm.
around the industry, but around our hospital and health system as well about this. And we are listening and we are talking it out.
Yep. Yep. It's all real time. I mean, the
Yes.
conversations I'm having with you, the conversations I'm having with others, it is literally not like we've got it all worked out and we're good. It's here's what we're trying and we're going to keep an eye on it and
Hmm.
we'll get back to you or we'll talk
Yep.
down the road. So it's all real time, which is fascinating. Um, when you talk about nurses and what they're dealing with, I think of a high pressure environment. I think of having a lot of patients. I think of family members wanting to talk. I think of
Hmm.
physicians who are not always the easiest folks to get along with.
Hmm.
So I think of a very fast-paced, high-pressure environment. And what that makes me think in the context of what we're talking about is you want to roll out these tools very thoughtfully because there isn't that amount of time. There isn't a half hour to hit a speed bump because somebody rolled out a tool poorly and there's a new button on the screen. And I don't know what it does. And I don't,
Yep.
you know what I mean? So
Yeah.
you have to be so thoughtful because of the pressure and the workflow that we really got to do this smoothly so we don't blow up your day, right? We help you. So your thoughts there?
So we have this out and live ambient on several units. And some days we're like, what happened? We didn't see that much activity. Oh,
Mm.
we started out the day with two rapid responses. A patient fell, and there were three call outs. And you're like, okay, got it. Totally understand. This is not why they went into healthcare, right? They're trying to care for people. They're trying to get them out of the hospital so they can go home and heal. So that kind of understanding of the environment around them is so critically important, which is why my whole team is clinicians and they have walked a mile in these shoes and they understand what it means to walk into a chaotic morning and to have to refocus all of your priorities to get you and your surrounding colleagues and your patients through that day. So
Yeah.
it has not been a dull moment since this started, and we're just keeping that in mind.
Yeah, you made me think of a story I heard about someone had a, a business continuity drill planned,
Mhm.
and they had to hold off because all
Mhm.
signs of codes came in, like the
Yeah,
operations blew up, and they're like, "Well, no, we're not going to do
not
it right
today.
now." Right. Which is probably when the thing's actually going to happen, right? The bad things
Mhm.
don't happen when everything's going well, but
That's right.
you certainly don't want to interrupt care for an exercise. So Yeah, so that's about rolling things out. Let's talk about the tool development. You're in Epic Shop, right? I know you're
Mhm.
rolling out Workday as well, which is we don't need to really get into that. But you're an Epic Shop. When you talk about ambient AI, Epic was a little late to the game on this, so a lot of the niche solutions came out, gained some
Mhm.
popularity. Now Epic's in the game, and some of those customers are coming back to their tool, that sort of homegrown tool. It's not, it's slowly, this is the dynamic we see all the time with this kind of thing. So if you want to tell us at all about where you are in that, the upsides of being with the in-house tool, there's an integration upside there. That's all a balance. So, because you mentioned ambient AI tools being built around nursing, I was wondering, who's building them? Because then Epic's got the agent factory out now where there's different
Mhm.
things you could do. So, your thoughts there?
This is where the airplane is already flying, but we're trying to build it. I feel that's in my soul lately. So where we're at from a Jefferson nursing perspective and public knowledge is that we are piloting the Abridge version of nursing, and we are piloting, just recently started the Microsoft Dragon version of ambient nursing as well. So we have those two solutions on our separate instances of Epic. One is up in the Lehigh region and one is in the Philadelphia region at Abington. So what we're doing and what we're finding is that these tools are earlier on in the nursing space. You'll hear of dozens of people that are using them for nursing, but not hundreds and certainly not thousands.
Uh-huh.
So they're learning a lot from us too about what it means to implement this type of technology into clinical care. And that's where we're having what we're calling real talk sessions with our nurses to say, like, what is this? Where's the friction? Where are you feeling it? And that is directly working with these vendors to help them understand what this really means in 2026 healthcare
Hmm.
and the changing dynamics and pressures that staff is facing. We're absolutely talking to Epic about it, but I think they're really early on. And it's not always the best to be the first with Epic products.
Hmm.
Certain things really come together nicely, and other things are rapidly developed and deployed. So we are looking at some of their AI tools, and we will absolutely figure out what they are doing from an ambient perspective, which is really backed by Microsoft, and then go from there with them. But from a nursing perspective, we're not locked in with any single vendor. We're really looking at a bunch of them right now.
Yeah, and that makes sense. Is it that generally that makes sense? To keep your options open as much as possible and to have flexibility and to be able
Mhm.
to adjust. Some people talk about, shorter contracts, right?
Mhm.
If we're going to do a contract anybody, or especially a niche player, let's keep it on the
Mhm.
shorter side. Let's keep an eye on what's going on, in-house, so to speak, with Epic. Um, so that's just a way to approach things, right?
Yeah,
With how
for sure.
fast things are moving, you want to stay flexible.
Yep.
Yeah. Very good. Let's talk a little bit about the nurses' role in sort of. There's been a huge focus on disaster recovery and business continuity. Um, have you, whether or not that's being run by IT or IT security and the CISO working with emergency management? There's
Mhm.
stuff come out from the Joint Commission, from the AHA. There's a nationwide tabletop going on in a couple weeks from the HSCC. It's a big emphasis. Um, what about the role of nursing? Have you seen much? You guys have it in
Yeah.
many conversations. Thoughts around making sure nursing is involved? Obviously, a huge part of care. Making sure you're involved in those discussions.
Anthony, I came off of a meeting earlier today about this. And then late last week, I was in a business resiliency meeting as well. Nursing is absolutely at the table of this. IT nursing or clinical informatics, as I am, is also at the table because I personally was talking about the many different scenarios that can occur from an IT outage, whether it's your EHR or it's all systems or it's a network issue or um, your your Wi-Fi provider is down. I mean, there's so many different scenarios that can occur. The ability to prepare for it really comes from the scenario planning. What are the different scenarios available?
Right.
And then how do we prepare for them? Because it could be a flood, it could be a fire. But this digital darkness opportunity, the magnitude of it is truly, it touches everybody. It touches our ability to communicate through phones. It touches email. It touches our finances. It touches our operations. And then it touches patients. So nursing is 100%. I was on with our chief nurse executive, Dr. Kate Fitzpatrick, today, as well as our emergency preparedness team. And then IT, cybersecurity, everyone is involved. The like additional component that we were talking about today is how does the school get involved? How do we now get upstream of this so that we're teaching people as they are learning to
Uh,
become that clinician, what it means to not have your technology available? Or should there be a mass casualty situation? Let's teach them early so they come in with some of that experience and knowledge.
yeah, it was said to me the other day in an interview that a lot of the nurses had never charted on paper. So when they
Yes.
did a drill, they said, "Okay, your systems are down." They were like, "Well, we don't really know what to do."
Right.
So it's kind of wild, right?
Yeah.
Do you want the schools to go back to showing sort of both ways, so to speak?
I can't decide if it's the schools or if it's a part of onboarding and an
Mm.
annual competency. Is what do we do when we don't have all of our bells and whistles available to us? And how do we prepare for that situation? The residents that are coming in, do they know how to put paper orders in? Do we know how to run them? Do we know when we run them? And then how do you get communication back? What are your red phones used for? That type of thing. So I think it's a combination of in school mentioning it. I mean, if you haven't gotten out into the field and really had that real world experience, it's hard to even prepare for what a downtime means. But part of onboarding and then annual competency is where I really think it fits in nicely.
Yeah, it's a really fascinating topic. The analogy that comes into my head sometimes is when you ask clinicians to practice without the technology they're used to, it's like asking a carpenter or a framer to frame up a house with no tools. You wouldn't do
Yes.
it. You just simply wouldn't do it. But that's not an option sometimes. You can't just say we're closed, but you can. That's called diversion, right? But if
Hmm.
it's a
Yeah.
large enough outage, there may be the nearest health system may be in the same boat you are, and they say, don't divert anybody here.
Right.
So there are scenarios, talk about scenarios, that's the way to do it. There are scenarios where we don't have our tools and we still have to give care. We don't have
Yep.
any option. We can't send them out somewhere else. So what do we do? And that's what you're talking about. We have to know. We have to have a plan B, as unpleasant as it may be.
Hmm. It is absolutely, and I think that that's why figuring out what are the absolute things that can't go away
Right.
with AI, with all of the tools that we will have available us, how do we still train on physical assessment, critical decision making, and working through the care of the patient, the treatment of the patient, the preparing the patient for that discharge and then post discharge
Right.
without all the bells and whistles. The bells and whistles just enhance the work that we're doing and make
Right.
it more streamlined with better communication and probably better outcomes. But how do we do it with the Stone Age upon us and no technology to support?
Right. And what's interesting is there's two ways to think of technology when it comes to care. One is sort of the charting and capturing the information and
Mhm.
discussions, but then there's the actual gathering of the clinical information, which would be the imaging modalities, the blood
Mhm.
work. So you can if that's not available, then I've read this, I've read doctors say this, like now you're talking about like you really can't practice medicine very well. It's almost like it was 2000 years ago, or that's an
Right.
exaggeration, but whatever. That's different than me not being able to capture things from a data point of view, right?
Yes.
Those are different. Yeah.
Couldn't agree more. And that would to not have labs and imaging and medications, I mean, that would be more of a catastrophic end of the world situation, in my
Right.
opinion. But
Right.
it's about the movement of the information and how do we
Right.
get the information to it. We're going to have that single machine that can do the radiology tests, and we'll be able to, draw your blood and get them to the lab and then call back results and things like that. It just slows things down a bit.
Right. Right.
Mhm.
Yeah. So you can have lots of fun around disaster recovery and
Yes,
scenarios
forever and
that,
ever.
you could have a good time around that. So we covered a lot of area. Um, you do have that opt-in back to what we were saying, that opt-in for some of that ambient AI. You think that's the way to go? There's been other examples of not doing that, sort of, big
Mhm.
bang rollouts. It's not,
Mhm.
well, I'm going to stick with our old EHR. No, everybody's going to the new
Yeah.
EHR.
Yeah.
You're going with an opt-in type approach. I'm sure that's well thought out, but what's your thinking behind that? It's pros and cons, I'm sure.
We, there's pros and cons. We're doing both, if I may. So we originally started with the units doing this, the entire unit, everybody on the unit is doing this, and then we saw this like adoption and kind of roll off of using it. Because listen, you can still put your hands on the keyboard and type the information in, so you can't force people to adopt it. You can
Hmm.
really strongly say, like, come on.
Right.
But this, while we continue to figure it out, we really need people who are wanting to be a part of the transformation, wanting to be part of the innovation. And I think we'll see the climb from there once it gets out and nurses become the advocates for it, for this technology in their care. And then others will say, all right, you paved the way, so I'm ready to jump in now. With the another unit that we just rolled out, we did do the whole unit, and we're saying you're an innovation unit, try. We want you to use
There
it.
you
So there is an
go.
expectation that you try it, and it's gonna be bumpy. It's gonna
Uh-huh.
be more work, and it's that convincing of people. And they're like, "Listen, I could just copy forward or put my macro in, and it's just as easy." And we're like, "It's not though, because you're still taking the time away." And this is time meant to help you face that patient
Uh-huh.
and to engage them in that conversational care, to
Uh-huh.
get them more involved in the care that you're delivering to them, to return that humanity to clinical care. Because we put computers on walls and we can put computers on walls, and nurses, you can't help it. When you're doing this, I can type and speak at the same time, but you're splitting your cognition in two places. And this is to return time for the clinician to be with their patients. It's also the real hope is that it just returns time in general for said nurse to do whatever they want.
Yes.
Go to the bathroom, take a break,
Yeah.
go down to the cafeteria and have your lunch, or take a walk outside and take a deep breath. That's really what we're hoping for here. So yes, conversational care, human interaction with our patients, but time for our nurses and our clinicians as well.
Yep, makes perfect sense. On the physician side, I've seen
Mhm.
a lot of what we call physician builders in Epic. They call them physician builders. That seems to be a big thing. Do you see the same dynamic maybe happening on the nursing side where, um, nurses get, in there in either Epic's agent factory or whatever, and you just see sort of that same dynamic?
So partner closely with our physician builders, but we have this really awesome IT Epic team that is our Jefferson team, and it's made up of lots of nurses
Okay.
and other clinicians, and we kind of have them in their space. What we do is liaise and engage the clinicians in that. I don't know that I see a big run towards having our staff in their building and doing that, but I could be convinced otherwise as I see more of what this agent factory is.
So you said you have 30, 33, 34 informaticists under you. How do you handle the temptation, as it were, to recruit from, or maybe that's what you're supposed to be doing, to recruit from the nursing ranks and, oh, that there's a super user over there. She's really great, or he's really great. Hey, would you like to, but I don't know if the clinical side loves you poaching over there, how that works.
Luckily, we serve the clinical side, so they don't mind.
Okay.
I have very tight partnerships with my regional chief nurses, and we work together on this. And 34 informaticists for 33 hospitals is not that many people when we have
Hmm.
65,000 employees.
Hmm.
So it's I want Jefferson nurses. I want them to work with me. I want them
Uh-huh.
on my team. And so many of my team are Jefferson nurses. They were either in the education space as nurse educators, or they were frontline staff working in ICUs for 20 years, or working in the ED. I have so many emergency department. They're just chasing all of that fun
Hmm.
energy. But I love our nurses working for us. And it's a fun natural progression to move into a different space. So many nurses do, and
Uh-huh.
many, many, many stay at the bedside as well. So it's just a choose your own adventure kind of situation.
Do you have any kind of formal or informal process where you're looking to identify, you look for certain signals or qualities or attributes to say that, she'd be tremendous, and then you present it as an option. Hey, maybe not today, but maybe down the road. And maybe they get to that point in their bedside care where they're like, I got to get out of here. But I
Yeah.
want to stay, but this would be perfect because I love informatics, but I just
Mhm.
can't do bedside anymore.
Yeah. This is too funny. This actually happened this week with a student that's working with us on Ambient, and she's great. And I reached out to my staff who she's working with, and I was like, "Oh, we should talk to her afterward." So she is confident, but empathetic,
Uh-huh.
meaning that she can come out onto the units, and it doesn't have to be specifically about her. But what I would be looking for is someone who's walked a mile or two in the nursing shoes.
Oh yeah.
I didn't spend a significant amount of time at the bedside. I spent some time at the bedside. I worked in IT before that, then nursing, then moved into informatics. So I'm really looking for someone who can be on a unit with confidence when nurses are like, "Oh, why are you
Hmm.
here?" And say like,
Hmm.
"Hey, let me engage you. This
Right.
is about people
Right.
movement and change management. And if you can figure out how to be a nurse, I can teach you how to do technology. We
Yeah.
can figure that piece of it out.
Yeah.
It's all about education. It's all about embracing the people around you to be a part of the change. And like this nurse, like a little bit of snarkiness and a good sense of humor is also really helpful because
Right.
it can be high intensity and it can
Sure.
be a little bit of pushback, and you need a good sense of humor to say like, all right, we're going to work through this together. Come
Yeah.
on, join me in this. So that's a lot of what I work through, but nurses are very intelligent people who went through pretty intense training.
Yeah.
So they can fit nicely in the IT space.
Yeah. It's nice if that informaticist, when they're told, back off, you have no idea what I do, it's say, no, I actually do.
Mhm.
Right. So that's an important, and that's why there are
Yeah,
CMIOs and CNIOs,
that's
is
right.
because the CIOs with the IT background got tired of being told by the physicians to get lost, and so they
Yeah.
said, all right, let's put someone in the middle here who
Yep,
you'll listen to.
that's
So.
right.
All right, we're gonna wind it down here, but let's get a little high level. Some advice for your colleagues, your other CNIO partners out there. I don't know, sort of what the biggest. Maybe you tell me what the hardest parts of the role are, the biggest challenges, like for your colleagues out there. You probably know the core issues that are they're wrestling with, and maybe you feel like you've made some headway on some of them. So, your thoughts around that?
I think, not every hospital or health system has a CNIO, so we can like start high level with it, which is if you're a CNIO type, so you're the director of
Mhm.
informatics or something like that, go grab your physician partner and get linked up real quickly. That relationship with the CMIO
Yeah.
is so critically important. And then your CIO and your chief nurse executive or CNO. I mean, the dyad between the two of them to say IT is so important, but in healthcare, it's impossible without clinicians at it. Let's put that together and really get this role to be a solidified part of the package. So that's number one, get your CNIOs in there and get at the table. And then how do we do this going forward? Just being transparent, so wildly transparent about
Hmm.
what you're trying to achieve. I think people are sometimes like, "Is she telling the truth?" I'm like, this is not about replacing nurses. I love nurses. I want nurses everywhere. I would call on a nurse to do anything to care for my family. This is about enhancing the role of the nurse. So like transparency into the goals of what we're trying to do, deliver better clinical care, safer clinical care, enhance the well-being of our nurses because people are a little unwell right now. I mean, we're in post-COVID. Many of them were trained under very intense environments. And I think the number is 55% of our staff have 5 years or less of nursing
Hmm.
experience.
Hmm.
Well, it's 2026. That means they were training during COVID. So what are we dealing with in this new world? I don't know that we've seen this before
Hmm.
in our lives of what they went through and what they're now dealing with. So in understanding that with empathy, approaching with empathy is critically important. And then clinical nurses have to be involved in everything that you're doing. They
Right.
do. They know right now in June of 2026 what healthcare is. And even if you were practicing a year ago, it's a different world. So they understand the pressures. They understand the variability, they understand the intensity of illness that they're dealing with in a way that, unless you're still practicing, you can't understand. So it's all about involving our nurses in the design, development, deployment, optimization, and in the yes, no decision making when it comes to technology.
Yeah, so it's got to be worked out on the governance level, right? On paper.
100%.
It's got to be
Yep.
on paper. The committees have to have the representation. So that's where you start, right? Make sure on paper it looks good and then make it good in reality. But if it doesn't look right on paper, if the committees aren't there, if the nursing isn't on the committees, you're structurally going to you're going to fail before you even start, right? Because
100%.
when we talk
Yep.
about getting those voices heard, that's where you have to see it on the screen, so to speak. Does that make
Yep.
sense?
It does.
Well, the volume's not going away, right? The patient volumes aren't going away.
No, they're
So,
not.
yeah, it's good work. And I appreciate very much talking to you today. I've enjoyed our
Same.
conversation, and I hope we can catch up again down the road.
Yes, Anthony, thank you so much for thinking of having me on and for this engaging conversation. I really appreciate it.
You got it, Colleen. It's been great. Have a wonderful day.
Thank you.
Thank you.